So our next speaker is Dr. Neil Aggarwal. He's a visiting associate professor in the Division of Pulmonary Sciences and Critical Care. Dr. Aggarwal received his MD degree at Northwestern and did his internal medicine residency and pulmonary critical care fellowship at Johns Hopkins University. He's currently the director of critical care research within the Division of Pulmonary Sciences and Critical Care and has been here since 2021. Today, he's going to talk about optimizing oxygen targets in patients with acute respiratory distress syndrome. Dr. Aggarwal?
Yes, thank you, Dr. Ho, for that introduction, and Dr. Bruce for your talk. It was very interesting. Can you guys hear me okay and see my slides?
Yes.
All right, wonderful. So yes, as was said, I'm going to be talking today about optimization of oxygen targets. I don't have any relevant disclosures for this presentation. And in my talk today, I was hoping to describe sort of an arc of a story that really started at the bedside, transferred to the bench, and is now back to the bedside and hoping to complete its arc in the next short period of time. So I wanted to talk a little bit about how we understand ARDS using a relevant preclinical model that we developed, some of the clinical studies of oxygen targets in the ICU that have been both observational and in clinical trials, and then potential role for pragmatic trial design as we think about this area of research. And so why study ARDS? Well, so where I trained, as Dr. Ho said, it was a significant interest of mine. The intensive care unit was my favorite place as a resident to train. The acuity of the patients that were there, the interactions with the families were all things that I very much looked forward to. And at the time, pre-COVID, ARDS was an under-recognized entity. Despite its high morbidity and mortality, people didn't really talk about it very much. Yet it has an annual incidence of at least 200,000 with a mortality rate of 40%, and that's just in the United States. And in people that survive, there's an associated long-term morbidity in most, if not everyone. And so during my clinical training, there were two important studies that were published. One is a study known as ARMA. ARMA was done as a part of the ARDS network, which was funded by the NHLBI. And that study was one of the first studies in critical care in ARDS specifically to demonstrate a benefit to an intervention, in which case the intervention was to deliver a low tidal volume ventilation strategy to patients with ARDS, and that was found to be protective and reduce mortality. That study was led by a PI at Johns Hopkins, and so I think influenced a lot of us in our training. A second study came along that I think was even more important to the topic of this talk today. And that was done by the investigators at Mayo, where they did an ARDS epidemiological study. And that study demonstrated that about half the patients with ARDS, in half the patients, ARDS was present on admission to the hospital. But in the other half, the ARDS diagnosis occurred or was recognized during the hospitalization, suggesting that modifiable factors may be present. And in fact, when the health system implemented simple things such as judicious fluid resuscitation, elevating the head of the bed, using a lung protective ventilation strategy, as well as a few other things, the in-hospital incidence of ARDS was reduced in half. Yet the epi of the ARDS in the surrounding area remained the same, suggesting that modifiable factors were in fact important. So as I transitioned to pulmonary and critical care training and research fellowship, I thought about what other modifiable factors, such as supplemental oxygen, one of the most commonly prescribed therapies that we know of, could influence the severity of lung damage. So what was the rationale for oxygen to exacerbate lung injury? Well, this concept of hyperoxia-induced lung damage has been prevalent for a long time, yet a safe oxygen range was not well established. Some older work had demonstrated that perhaps 60% oxygen was safe in healthy adults, but there was a study that demonstrated that 2 days worth of 50% oxygen exposure actually produced oxidative stress and led to the recruitment of lung neutrophils, which was a hallmark of inflammation that was happening in the lungs. Furthermore, when you think about patients in the hospital, those patients are inflamed, and a safe FiO2 target may even in fact be lower in those patients. And so in patients with pneumonia or other lung pathology where supplemental oxygen is extremely common, perhaps we had a hypothesis here to study. And that was that oxygen as a second and potentially modifiable therapy may augment lung inflammation and injury and result in worse outcomes and potentially augmentation to the level of severity that we see with ARDS. So I took that to the bench and joined a lab at Johns Hopkins that was studying acute lung injury, or ALI, models. And we tried to apply the concept of oxygen synergy to that model. So the lab itself focused on understanding mediators of acute lung inflammation and resolution. And so this we treated as a mediator of acute lung inflammation, and we created a model that allowed us to study this synergy. So mice were exposed to intratracheal LPS, or lipopolysaccharide, which is an endotoxin. It's commonly used as an ALI model. We chose a sublethal exposure and followed it 12 to 16 hours later with a moderate amount of oxygen, 60% in this case, for 2 to 4 days. And in doing so, we demonstrated that in comparison to mice that received just intratracheal water plus oxygen, or just LPS, the white bars here demonstrate that the LPS and oxygen were synergistic in terms of the amount of protein that was leaking into the lung, as well as albumin, a marker of extravascular accumulation. And when we looked at the cellular profile, we saw a striking increase in the amount of neutrophils that were in the alveolar space. As I mentioned before, some of the human studies had demonstrated that neutrophils that accumulate are a hallmark of lung inflammation. And in fact, in ARDS, when pathology studies were able to be performed, neutrophil alveolitis, or the accumulation of neutrophils in the alveolar space, was a central feature. And so we went on to focus a little bit on the neutrophil part of the story and understood that neutrophil apoptosis and or its clearance were not different in the different groups. So that was not driving the increased injury. But in fact, there was a marked increase in neutrophil chemoattractants such as Kc and MIP2 that were increased in the mice that were exposed to LPS and oxygen. And when we looked at this a little bit further to see if depletion of neutrophils was going to impact lung injury, we in fact saw that exact finding. So on the left here, this is a histology. This is a lung in cross section. You can see that on the left, this is a mouse exposed to LPS and oxygen plus the isotype neutrophil depleting antibody. And there's a dramatic amount of injury that's occurring in this mouse, as we saw in our other experiments. But when you add a anti-GR1 or neutrophil depleting antibody, you can see that not only are the neutrophils not getting to the alveolar space, which I don't show, but the amount of injury that happens in the lung is markedly reduced. Similarly, when we look at the protein and albumin, this effect is present as well. So for today's talk, I don't have time to describe our related work in more detail, other than to say that we went on to understand that oxygen was skewing recruited and resident macrophages towards a pro-inflammatory phenotype. And when pro-resolution pathways were blunted or absent, this pro-inflammatory macrophage phenotype was quite striking and instrumental towards oxygen-induced synergy of acute lung injury. Subsequent to this, I pivoted towards a focus on macrophages, and our lab went on to understand and study external and internal macrophage skewing and its ability to alter resolution of acute lung inflammation and lung injury. But in parallel, given that I was a physician scientist, I began to think about how to transition these findings of the bench back to the bedside. So to begin to study this, we started to look at patients, ask the question in patients who were in clinical trials and had ARDS, were they exposed to above goal oxygen in these clinical trials? And so we first did a retrospective assessment of 10 ARDS network trials that were conducted in the late 90s and early 2000s, including University of Colorado as a participating site, and targeted an SpO2 range of 88 to 95%, or a PaO2 of 55 to 80 millimeters of mercury. These are thought to be safe and otherwise normal levels of oxygenation. And our question was, how common was the above goal oxygen occurrence in these clinical trials, very regulated and protocolized settings? And was there any association with clinical outcomes? We defined for our study above goal oxygen exposure as any FiO2 0.5 with the maximum amount being 1 when the PaO2 was greater than 80. And we calculated the difference between what was the delivered FiO2 minus 0.5 and summed it over the first 5 days. So in this study, I want to show a table here that shows that we had a pretty large group of patients that we were looking at. This was 10 trials, and there was more than almost 3,000 patients in these 10 trials. And you can see here when you pay attention to the columns on the right that there are several subgroups of patients that were exposed to excess amounts of oxygen. And cumulatively, about half the patients in all these studies were exposed to excess amounts. Again, that was despite being in a clinical trial setting and a very robust trial committee and group that was existed for more than 20 years. And there was an association, which we'll come to in the next couple of slides, with oxygen exposure and worse outcomes. Looking at this graphically, we can see that for the group that had mild ARDS, defined by their severity based on their partial pressure of oxygen to the amount of oxygen being delivered, or so-called P to F ratio, we see that in black, these are the mild ARDS patients, in red, these are the moderate, and in blue, these are the severe patients. And when you look at the percent of participants on the y-axis and the cumulative oxygen exposure that's in excess on the x-axis, you can see that in all groups and at all severities, there's an increase in exposure to excess oxygen. And in fact, if anything, the more severe patients are exposed to higher amounts of excess oxygen. And when you look at that relationship to outcomes, you can see that the probability of death at 90 days, as well as the log odds of death, are both increased as the increasing oxygen exposure occurs. That's in excess of what is the target range. Now, this may not be surprising because as ARDS severity increases, the mortality also increases. So we wanted to look at the question, dividing up the patients into their tertiles of mortality. Again, mild, moderate, and severe. And if you focus your attention on each of those subgroups, and specifically the black lines, which denote the most amount of oxygen exposure that was in excess, you can see that at all tertiles of severity, there's an increased odds of death happening in the setting of excess oxygen exposure. Now, we were not the only group studying this. In fact, there were several other observational studies that were happening during this time frame. What I've highlighted for you in the green boxes are the studies that were done in patients with ARDS. And as you can see, there's only 3 of them in comparison to a broader group of patients that were receiving mechanical ventilation and being in the ICU. And despite variable oxygen metrics here in the middle column, you can see that for the majority of the studies, though not all, there was an association between hyperoxia, that is the excess oxygen exposure, and mortality, even if you adjust for severity of illness in these models. Looking at one of these in particular, this was a study done by Van den Boom that looked at 2 ICU databases in the United States. And the criteria for this study was that the ICU patients had to be receiving at least 48 hours of oxygen therapy and have at least 24 values, SpO2 values, that's the pulse oximetry, to be collected and measured. And when they adjusted for things like age, BMI, sex, and SOFA score, both of the studies demonstrate essentially a bimodal relationship between the probability of mortality here on the y-axis and a median oxygen saturation target, with a nadir of mortality happening right around 96%. This bimodal relationship is important because I think it accounts for severity of illness on the left side here, but perhaps, and in both cohorts, you see this, a suggestion that excess oxygen exposure was associated with worse outcomes. So of course, these observational studies are not causal. And so in the same time frame or soon thereafter, there was a few clinical trials also performed that were looking at oxygenation targets in ICU patients. And so highlighting here are 5 of these clinical trials, only one of which, shown in the red box, was done in ARDS patients. Again, this brings up the theme that there's probably easier to do these studies in a broader population, which we'll come back to in a little bit. If you focus your attention on the first of these studies called OX-ICU, you can see that in this case, there was an improvement in mortality with what was described as a conservative oxygen target, and that was a PaO2 range of 70 to 100, or an SpO2 target of 94 to 98%, in comparison to a PaO2 of up to 150 and an SpO2 target of 97 to 100%. So if you looked at just this trial, you would say, well, the lower oxygen target is associated, has a decreased mortality, and these patients were actually randomized. So this is an important finding. However, subsequent trials modified this thinking a little bit. So the important point about these subsequent trials is that the liberal arm target, the higher dose oxygen target, were different. They all targeted a PaO2 in the 90 to 100 range and not up to 150. That was done in the previous trial that showed benefit. And in addition, the conservative arm was also somewhat lower, and O2 target was also lower in these three trials. So somewhat not surprisingly, perhaps because of the lower liberal arm target, there was largely no difference in important clinical outcomes, including ventilator-free days and mortality. And in fact, one of the trials was stopped early because of an observation of 5 events of mesenteric ischemia in the conservative arm, suggesting that there was an inadequate oxygen delivery to those particular patients. Now, one thing to point out here is that this trial was done as an open label study, which means that there were noticeable management differences between these two arms. From a clinical standpoint, another thing to note about this trial is that there may be a plausible explanation in that there was a much higher proportion of patients who had sepsis-induced ARDS. And in other studies, previous work has shown that sepsis may need a higher oxygen target because of important amounts of tissue delivery. So this concept of heterogeneity of treatment effect is an important one that we'll come back to. So I already alluded to a positive trial that happened in ARDS, and that was the low tidal volume trial that was done by the NHLBI network. It was published in 2000. It was a landmark study, and it demonstrated a 9% reduction in mortality, pretty significant for this important clinical condition and for this sick patient population. And this trial was built on a couple decades of preclinical research demonstrating the harmful effects that higher ventilator tidal volumes had on lung injury. However, a subsequent study to this, published about 15 years later, was called LungSafe. It was a large international observational study that demonstrated that more than 80% of patients with ARDS received tidal volumes that were higher than recommended, above the red line, or in some cases injurious, above the orange line, about a third. And this study was performed 15 years later, which means that the effects that were seen, the benefits that were seen in the prior study hadn't been replicated despite it being 15 years later. And the question was, why was that? Well, that brings me to the last part of the talk, which is the comparison of traditional or efficacy-based clinical trials versus pragmatic trials. So this is an important area to think about when it comes to critical care. And these trials are very different in their construct and very different in the types of questions they answer, and hopefully will be something that we look at here going forward. So in the traditional RCTs, you're looking at questions that are asked under ideal conditions. So you have a very defined inclusion and exclusion criteria, and you've got, in most cases, a treatment versus placebo or a treatment versus non-treatment. And you tend to randomize patients at the individual level. ARDS studies typically fall in this category. In contrast, pragmatic trials are asking the question, does this intervention work under usual conditions, or otherwise what we would encounter in most of our hospitals? Therefore, the population is diverse, the representation it has broader inclusion and exclusion criteria. You oftentimes leverage clinicians and those that are at point of care with the patients, with researchers. So you're using data that's in the EHRs and embedded in registries as a source of your research data. And you're asking questions that are really comparative effectiveness of real world interventions. The randomization may or may not be different, and you're really looking at multiple settings. And so for the studies that we've seen so far, this would fall sort of in line with acute respiratory failure with otherwise broad criteria. And so there are examples of how this approach, the successful pragmatic clinical trial research, has occurred. There's a study done by Vanderbilt where they used a very pragmatic design, randomized patients based on the ICU that they were in at a given time, and really looked at 2 different interventions. One was saline, and the other was using balanced crystalloids to mimic plasma, administered to patients who required any type of fluid resuscitation. They enrolled 15,000 patients in 16 months, which is a phenomenally fast enrollment rate. And they saw some effectiveness to the balanced crystalloid strategy. And although the number needed to treat in this trial was 94, I would point out to you that there's more than 5 million patients admitted to the ICU every year. And this intervention done in this trial would be perhaps very easy to implement, since it was just involving 2 different types of fluid resuscitation. Now, studies this large, I think, bring up something else that's very important. And one is that one part of it is you're allowed to look at subgroups that are important and may be different in terms of their baseline risk, so-called heterogeneity of treatment effect. And so in this trial, they looked at sepsis patients, and despite it being a subset of patients, there were still more than 1,000 patients in each arm of the study that had sepsis. And here, as you can see highlighted in the red box, there's a clear benefit to balanced crystalloids in that arm in terms of odds ratio. So taking us back to the oxygen targets in critically ill patients, what is happening right now with respect to pragmatic research? And there's a couple of important studies to point out. One is a large international study called MEGAROX. It's a trial of 40,000 intubated ICU patients with a 90-day hospital mortality outcome. And really what this trial is looking at is a series of registry-embedded clinical trials where the trial is designed to allow for something very innovative called response adaptive randomization, which basically adjusts patients to more favorable treatment outcomes as the trial results come in. Now, in addition to that, because it's so large, this trial is going to be equipped to look at sepsis and hypoxic encephalopathy as two important causes or subsets of populations with respiratory failure. And in this trial, they're looking at a conservative oxygen target of 91%, and with an alert basically built into the clinical decision tool that if the 95% oxygen or more exists, the FiO2 needs to be reduced. And in fact, locally, we have another study called SAVO2 that I think also highlights something that's important. And that is, again, using this concept of multi-site randomization, multi-site trial with hospital level randomization, targeting what is a normoxia population or normoxia target in their group, 90 to 96%. But importantly, this trial is using educational and training strategies that include what's called a best practice alert or BPA to help implement the design of the study. Again, both of these trials I'm highlighting to you because they have pragmatic features that may be important to this patient population. So what's next for us and where is the innovation, as this is a research and innovation conference? So I would argue that the ongoing trials are innovative in their design. I mentioned to you MEGAROX, which is looking at heterogeneity of treatment effect, as well as responsive adaptive randomization. Despite these trials being pragmatic, they're generalizable and suited for clinical adoption. And the use of something like a BPA that is embedded in the clinical decision tool to nudge or assign arms, I think is pretty innovative in and of itself. So what are we doing here? We are collecting SpO2 data on patients in acute respiratory failure at University and UC Health and in collaboration with some colleagues inside the department and outside. We're hoping to partner, and I've had introductory conversations with Vanderbilt's Pragmatic Trials group that has been thinking about this for a long time and to contemplate potential trial opportunities and potentially even join the MEGAROX study that is ongoing, will be going on for several years. Now, as I mentioned to you, there's ongoing trials that may answer key SpO2 target questions in acute respiratory failure. And if they do, and they're successful, whether it's in the overall population or in important subgroups with the heterogeneity effect, well, that's great. And in which case, I think our goal here would be to implement some of these evidence-based oxygen targets using BPA nudges or other clinical decision and support tools. And I think there's interest across the department and in other departments to do this type of work as well, which takes us back from bed to bench and back to bed again. So just want to acknowledge some of the collaborators that are growing here at the University of Colorado, Mark Moss, the PI of the Critical Care Trials Group for a long time, as well as some previous collaborations at Johns Hopkins and ongoing ones at Vanderbilt. And I'll take questions. Thank you.
Great, thanks, Dr. Aggarwal. So if you have any questions for Dr. Aggarwal, please enter it into the chat. So yeah, I had a question, and I've been interested in this, using the HR to conduct pragmatic trials and the issue of using nudges, right? So what, have there been prior studies looking at nudges to impact, physician behavior in the ICU, and what kind of nudges do they usually use?
Yeah, so one that I alluded to that's actually being done here is called SAVO2. And so that does involve a BP. So in addition to the education of the ICU units, that trial does involve a BPA nudge where the best practice alert is observing when the SpO2 is above the target range and then provides the nudge or the BPA to the provider teams to tell them that, that there's A, data to support that the range is appropriate, and B, that they should consider lowering it in the right clinical situation. For all of these nudges and the things that are happening in the clinical realm, I think it's important to point out and be explicit that the clinician provider override for a particular patient based on their gestalt or their assessment is important, because that I think happens in the real world. There's also a trial that's happening that involves not just a BPA nudge, but in fact a BPA-based decision. And so this is a study that's looking at 2 different antibiotics for Pseudomonas. And basically, if the patients meet the inclusion-exclusion criteria, the provider is alerted that they've been randomized to one arm or the other, and that arm is based on whether they're delivering a penicillin-based anti-Pseudomonal or a cephalosporin-based anti-Pseudomonal. And again, important to point out that the physician and the provider, they have the ability to override this, but that's built into the to their EHR and their clinical support tool.
Great, thanks for that. And I don't see any questions in the chat, so maybe with that we can end this session early and give people some time back. So again, thank you, Dr. Bruce, Dr. Aggarwal, for really interesting talks. And if anyone on the line has questions, you can also directly reach out to our 2 speakers today. So thank you again for some fantastic talks.